Welcome, future nursing officers. Right, so if you're gearing up for the NORCET 10 exam, you are exactly where you need to be. Think of this explainer as your ultimate old versus new survival guide. Look, medicine is evolving super fast, and you know what? The examiners absolutely love testing you on what's changed. If you're still relying on outdated clinical habits, you're literally going to fall right into their multiple choice traps. So we're going to lock in the exact 2025 and 2026 evidence-based updates you need to confidently conquer those questions. Let's do this. Today, we're going to be covering a lot of ground. We'll look at the latest BLS and ACLS guidelines, ATLS and trauma care, stroke and cardiac updates, the new sepsis 2026 protocols, and wrap up with tuberculosis and some general updates. Okay, let's dive right into this with our first major section, BLS and ACLS guidelines, specifically those AHA 2025 updates. Right out of the gate, we've got a massive change. The old way taught us to check sequentially, and more importantly, to actually stop compressions to deliver breaths. Well, you need to completely erase that from your memory. The new mandate is a simultaneous pulse and breathing check in under 10 seconds, with absolutely no delays. But here is the biggest distractor you're going to see. You do not stop compressions to deliver those breaths anymore. The ratio, it's still 30-2, but those compressions must remain continuous. So if an exam option says stop compressions, do not click it. No way. All right, let's rapid fire through some really incredible high-yield facts. For CPR in pregnancy, manual left lateral uterine displacement is now explicitly mandatory. Got it? For choking adults, you aren't just doing abdominal thrusts anymore. They've actually added 5 back slaps, just like we do in pediatrics. Moving to ACLS, we have some really strict quality metrics now. Your end-tidal CO2 must be at or above 10 millimeters of mercury for quality compressions. And your pre-shock pause, strictly under 5 seconds. Finally, our classic reversible causes have evolved. It's no longer just the 5 H's. Welcome to 6H and 5T. Yep, hypoglycemia has officially been added to the H's. So when you achieve ROSC, or return of spontaneous circulation, the targets have been heavily fine-tuned. Notice the subtle drop in oxygenation targets here. We are now aiming for an SpO2 of 92 to 98%. It's not the old 94 to 99% anymore. Hemodynamically, they've really drawn a line in the sand. Mean arterial pressure must be maintained exactly at or above 65, with a systolic over 90. And interestingly enough, aggressive hypothermia is kind of de-emphasized now. The focus is squarely on aggressive fever prevention instead. Moving right along to Section 2, let's talk about the recent updates to ATLS and trauma care. I want you to mentally prep for the emergency room for a second. Imagine this classic exam scenario. A trauma patient rolls in with severe, catastrophic, visible bleeding. So what is your absolute first priority as a nursing officer? Well, if you immediately thought, oh, secure the airway because of the old ABCDE rule, you've totally fallen for a classic distractor. The new primary survey algorithm is XABCDE. That X right at the front, that stands for catastrophic hemorrhage. You absolutely must manage massive visible bleeding first. We're talking direct pressure, tourniquets, or even a reboa balloon for advanced aortic occlusion, all before you even touch that airway. Seriously, do not let your old reflexes cost you points here. So the crucial point here is understanding these anatomical shifts. For tension pneumothorax, you've probably always been taught to hit the second intercostal space, midclavicular line, right? Well, recent evidence actually proves the lateral approach is far superior. Your preferred needle decompression site is now the 4th or 5th intercostal space using the lateral axillary approach. That's the exact same spot you'd place a chest tube. Watch out for this one, it is a guaranteed test maker favorite. And when it comes to trauma fluid resuscitation, the whole era of just blindly pushing 1-liter boluses of crystalloids like normal saline or Ringer's lactate, yeah, that's over. If blood products, specifically whole blood, are available as an option on your exam, you must prioritize them over crystalloids, every single time. Okay, on to Section 3, stroke and cardiac updates. The overarching theme for this entire block is pretty simple. Time is tissue. Now, what's really interesting about this next part is the definitive drug shift. For acute coronary syndrome, sure, you still need that ECG within 10 minutes of first medical contact. But look at the meds. Ticagrelor is now actually preferred over our old reliable, clopidogrel. Also, radial access is officially mandated as the preference for PCI. Shifting to hypertension, stage 2 is explicitly defined as greater than 140/90. And the new rule? You don't start with monotherapy here anymore. Stage 2 requires immediate dual drug combination therapy. Let's talk stable pulmonary embolisms. We used to instinctively reach for low molecular weight heparin, like enoxaparin, as our first-line treatment. Well, that habit definitely needs breaking. The new preference for eligible patients is to go straight to oral anticoagulants, like dabigatran. Okay, I want you to literally burn this number into your brains. 1,000. In the New Year's algorithm for pulmonary embolism, if a patient meets 0 clinical criteria, the D-dimer threshold to confidently exclude a PE has actually been raised. It is now 1,000. It's no longer that strict 500 cutoff we used in the past. And when you're dealing with a stroke, remember, time is brain. We used to nervously delay contrast imaging to wait for kidney function tests, worrying about acute kidney injury. But the new guidelines are passionate and crystal clear on this. Do not delay a CT or MRI waiting on a KFT. The minimal risk to the kidneys is vastly outweighed by the massive benefit of saving brain tissue. If a test scenario asks if you should wait for lab results to image a stroke patient, the answer is a resounding absolute no. Let's transition into Section 4, the highly anticipated Sepsis 2026 protocol updates. Fair warning, the old screening tools are officially out. Because critical care nursing is all about early recognition, right? So if you see QSOFA or SOFA on the exam as the preferred screening tool, it's a total trap. It's outdated. The 2026 guidelines have moved away from them in favor of higher sensitivity scores. You absolutely must look for options like NEWS, NEWS2, MUSE, or the SIRS criteria. These are your new gold standards for spotting sepsis early. And the resuscitation roles? They've been finely tuned as well. Antibiotics are still needed within 1 hour for actual septic shock, but you now have a 3-hour window to evaluate for merely possible sepsis. Our blood pressure targets are also more permissive now. A MAP of 60 to 65 is completely acceptable. But here is the massive critical care change. You no longer have to delay vasopressors waiting for a central line. Peripheral IV vasopressors are now perfectly acceptable to get that blood pressure up quickly. And this brilliantly illustrates a major shift away from blindly pushing fluids. The guidelines explicitly warn against fluid over-resuscitation. Instead of just pushing fluids because you can, perfusion targets are now a dual-check system. You must monitor serum lactate alongside capillary refill time, which should be under 3 seconds. These 2 clinical markers tell you exactly when you need to stop unnecessary fluid pushing. All right, moving into our final section, Section 5, Tuberculosis and General Updates. TB regimens have seen some massive exam-worthy overhauls. Let's walk through this because it's absolutely crucial. For drug-sensitive TB, the old HRZE regimen is making way for the new HPMZ regimen. Notice what's missing there? Ethambutol and rifampicin are completely gone, replaced by rifapentine and moxifloxacin for an intensive 8-week phase. But the most revolutionary change is in multi-drug-resistant TB. Those agonizing 18 to 24-month regimens involving painful injectables, they have been completely scrapped due to toxicity. The new standard is the B-Palm regimen, made up of bedaquiline, predemonid, linezolid, and moxifloxacin. It's completely oral, it's highly effective, and it only lasts 6 to 9 months. Game changer. Okay, I want you to quickly lock these standalone facts into your short-term memory for direct multiple-choice points. Ready? For high-risk diabetes, SGLT2 inhibitors are now preferred even before metformin. In heart failure, don't step up therapy, you start quadruple therapy all at once. For status epilepticus, levetiracetam and valproate have booted phenytoin right out of the second-line spot. In post-op pain, ditch the tramadol, Fentanyl patient-controlled analgesia is the priority. And for uncomplicated UTIs, avoid fluoroquinolones entirely, use nitrofurantoin or fosfomycin instead. Before we wrap, I'm going to give you one final terminology update that examiners absolutely love to use to trick you. When you correct hyponatremia too rapidly, the resulting brain damage used to be called central pontine myelinalysis. Well, that name has been officially retired. You now need to identify it on your exam as osmotic demyelination syndrome. Wow, we have covered an incredible amount of ground today, unpacking the exact shifts that separate the prepared from the unprepared. You now know the common pitfalls, the updated thresholds, and the precise modern clinical pathways. So the only question left is, in the intense heat of the NORCET 10 exam, when an option looks comfortably familiar, will you fall back on your old habits, or will you trust the new evidence we've just mastered? Trust the evidence, apply this precise knowledge, and you will absolutely dominate this exam. Thank you so much for exploring these updates with me in this explainer. Keep studying hard, and I'll catch you next time.